Dr. Shushmita, working as a critical care consultant in Andhra Pradesh. First, I would like to thank Tapa sir and his team for giving me this wonderful opportunity. Uh, I have done my EDIC exam very recently. Uh, Being a part of TRICS group is very delightful. Sir and the other team members have uh, formulated the question and answers in a very well structured way. Though it is seems very simple, but conducting or making those answers very simple is a very complicated thing. And I am so much grateful for being a part of this. Yeah. And
Thank you, Dr. Susmita, for those nice words. We definitely feel happy that yes, you have joined our course, and we also wish you all the best in your upcoming endeavors.
thank
And
you.
I hope that you will be also clearing this EDIC 2 exam, which is like the result is about to be announced. So, do we have Dr. Bhagyasri? Do we have Dr. Jitendra? Dr. Jitendra has joined.
No, sir, he is going to join soon.
Okay, okay. Now I also welcome Dr. Sakshi Sharma. Dr. Sakshi,
Yeah, I'm just starting my video
no
also.
problem, no problem. So Dr. Sakshi is also one of our the delegate in our recently concluded TRICS 2 course. She has also appeared the EDIC 2 exam, and she has also taken our request seriously to share her own experience as well as the questions those were like being those were asked to Dr. Sakshi, and she has collated those questions. Though again, I am sharing the disclaimer that those questions are never exactly the same questions those were asked. We have tried to again reformulate, I would say, in medical terms, or we have actually reformatted those questions so that it should not be copying from the exam, and we are only sharing with you the domains those were asked in the real exam. So am I right, Dr. Sakshi? If you can
Yes,
introduce
yes,
yourself
yes,
and a
sir.
few
So
lines.
I'm Dr. Sakshi. I work as an intensivist in Mumbai. So I just appeared for the EDIC 2 exam and I had joined the TRICS 2 classes for that. So I sir requested that I make like a recall, exam recall. This may not be 100% accurate, but I tried to capture the gist of the exam and what they were trying to ask and what the pattern was, more importantly, because most of us are very unaware about the pattern and the timing of the exam, how fast the exam goes. So I thought maybe this might be helpful, hopefully.
Yeah, thank you, Dr. Sakshi, for taking your like busy time apart from your clinical work. Now, I also welcome our co-faculty of this course for many years, Dr. Jitendra. Dr. Jitendra is senior consultant critical care at Apollo Hospital, Bengaluru, and Dr. Jitendra has contributed to the knowledge as well as the expertise of many trainees. So we are really delighted to have him also as one of the faculty for this session as well as our upcoming tricks too. Dr. Jitendra?
Hi, sir. Hi, everyone.
Yes. Hello.
Hello. Good
Dr.
evening,
Jitendra,
sir.
if you can share
Good
with you
evening.
us some of the your like salient points about our recently concluded tricks too, as well as wishing them all the best before we start our webinar for today.
I think I don't know how many of them have joined. Not many have joined as of now. I
So
think there are
55,
60.
Dr.
Yeah,
Jitendra, it's only
nearly
55,
nearing
so
60.
don't worry.
Hmm.
It will gradually
I think
increase.
few more will join as
Yes,
expected. So
yes,
that's what I mean. We'll be just touching up and mainly we'll give an idea of how these exams will happen. So we'll not be teaching entire thing here. So, and we have one of our student who was part of the TRICS 2 module. She's been part of the TRICS sessions. So she's taken up her exam. So she'll be sharing her experience. And as she rightly said, we can't, I mean, exactly mimic what the questions were, but we can know what they were trying to ask or what particular field of or whatever system they were trying to cover. So, I mean, these will again will be extensively covering in our modules again, which is just
yes,
a brief roundup so that everybody will have a rough idea of how these exams would be.
yes, yes. Thank you, Dr. Jitendra. And with this,
Mm.
I also welcome Dr. Sanant Kumar Das from Australia. So he is also the co-founder as well as the director of 360 Critical Care. So Dr. Sanand has again, just right now landed in, I think he is traveling to Adelaide, but still he has taken time out to join this webinar to share his own thoughts and also contribute to the knowledge of the upcoming trainees. So Dr. Sanand, welcome.
Yes, thank you. I've just actually checked into my hotel. Um, uh, it's a wonderful program, that's what I'll say. And I think from our feedback that we got and looking at the previous year question, all the three questions have been covered in our last tricks. Out of four, three questions were already four CCS, three CCS were already covered in our last trick session, which is really amazing. I'll not take much time, and I will leave the stage to um, whoever is presenting today, and I'll be in the
Yeah.
background if there is something I'll be adding on.
Yes,
Thanks,
yes.
Tapas.
Thank you, Sanant. So before I would be handing over to Dr. Susmita. So to start with the CCS section, so few points that I want to share with you just to motivate you and to start the journey of EDIC 2 preparation. Maybe you are joining our TRICS 2 course or not. That's a completely different thing. This is nothing related to our this recall webinar or the upcoming free webinar that we would be having maybe towards the end of this month. So, welcome, friends. We all know that you have dedicated your almost 8 to 10 years or more than that in critical care, in learning the ABC of critical care. Now, you are coming to the phase where you are going through a tough phase of EDIC 2 preparation. You have already crossed the first hurdle, that is EDIC 1, or maybe some of you are actually planning to appear the EDIC 1 and following that EDIC 2. So when the going gets tough, only the tough get going. That is the message that we are learning or we are remembering since our day one in our school days also, college days also. So I am not, maybe I would not change the statement, but rather I would say that it's not the only hard work that is important, rather the smart work which is better. And in current scenarios, in current competition, where it's like stiff competition, I would say you have to have smart work, and the smart work comes with smart academies or the trainers or the mentors. So from 360 critical care, we are happy to conduct this first free recall webinar in our series of webinars and also the course finally, that is tricks 2. And this is not conducted, maybe I would say, for 1 year 2 year, for last 3.5 years we have already crossed 7 EDIC 2 exams consecutively, and you won't believe that the passing percentage is staggering, I would say 95%. And that's the reason we thought about making one recall webinar. Previously we were not having, last time only we had the recall webinar. So this is something to just analyze the current trend, what is happening, what is being followed in the EDIC 2 exam, real exam. This is a European exam, definitely very demanding and prestigious. So just for your information, if somebody is curious what when will be the next EDIC 2 exam, so EDIC 2 spring 2026, the exam dates are, please note it down, May 19th and 20th, 2026. And the registration deadline is February 3rd, 2026, 10 a.m. CT. So this is something for you all. And I am not taking much of your time. This is a very, I would say, concise webinar where we'll be focusing only on the trends. So I am just handing over the discussion to Dr. Susmita. Dr. Susmita would be discussing with the CCS section. And then following that, we would be, Dr. Sakshi, Dr. Jitendra, and myself would be taking you to the CBS. What are the questions that were asked in the recently conducted EDIC 2 exam? Thank you, Dr. Susmita. And I would definitely request Dr. Sanand to please moderate the session. If anything is missing, any highlight points that we want to share with our candidates, and also Dr. Jitendra as well as Dr. Sakshi, everyone is invited to participate in this discussion.
Okay, sir.
I am sharing with you, Dr. Jyoti. Don't worry. I am posting in the chat box about the EDIC 1 dates.
Yeah. Can you see my screen, sir?
Yes, yes.
Yeah. Yeah. Once again, good evening, one and all. Thank you, Tapas sir and his team for giving me this opportunity. And before going to the actual recall part, first I would like to share a few points. In the EDIC Part 2 exam for the CCS, we will be given three scenarios. The question part carries around 25 minutes each. But before that, you'll be given the whole, like most of the case scenario, and you'll be given 10 minutes time for each case to read. In that 10 minutes time, you can read the scenario, and with practice you can form your basic questions. Most of the scenarios, the first few questions will be like, what will be your differential diagnosis, or what is your interpretation from the lab or the arterial blood gas analysis, and like what is your immediate priorities, or what is like um, first immediate steps or immediate investigation. So first few questions will always be based on that. So in when you're given the 10 minutes time before each case scenario, you can read the scenario and formulate yourself those questions and prepare the answers beforehand. So this will fetch you a lot of time in subsequent questions, as far as I know. So, so going ahead with the case scenarios, and once again I would like to say that this is a just a gist part. This is not the actual case scenarios what we have given, and this is how like the examiners were asking questions. I'll just give a gist about that. So this is the first case. A 48-year-old, one second. Yeah, a 48-year-old male with no comorbidities presented with a 5-day history of progressively worsening bilateral lower limb weakness. He reported a recent upper respiratory tract infection and diarrhea in the preceding week, and noted new onset shortness of breath and difficulty swallowing. Currently, he is on nasal flow, high flow oxygen with a FiO2 of 0.6 and the flow of 60 liters per minute. On examination, his heart rate was 94 beats per minute, blood pressure was like 150 by 80, respiratory rate was 32 beats per minute, saturation is 80% on room air. On auscultation, both sounds are heard, heart sounds are heard, and RS, preparations were heard. On CNS examination, bilateral limb weakness, which is more predominant in the upper limbs than in the lower limbs, and there is a complete areflexia and poor cough and gag reflex. The investigations part, the ABG is like the pH is 7.43, PCO2 is 36, PO2 is 58, bicarb is 23, lactate is 0.8. Hemoglobin is 13.1. Total leukocyte count is 15,000. Platelets 1.6 lakh. Creatinine 0.8. Urea 24.7. Sodium 138. Potassium 3.5. Chloride 109. Total protein of 5.9. Albumin is 4.4. Creatinine kinase is 306. BNP is 60. CRP is 10. As I told you, most of the first few questions will be like summarize the findings or summarize the case, what we have given, or interpreted the lab abnormalities or the ABG analysis. So first, what is your ABG interpretation from the above case? So it's a primary respiratory alkalosis with acute hypoxic respiratory failure and a raised arterial alveolar gateway. So whenever you are given an ABG in CBS or CCS, practice is always the key. So you need to practice multiple number of ABGs to get the better diagnosis or better conclusion in least amount of time. With practice, I can say you can hardly make an ABG interpretation within 1 minute. So it is more than sufficient. So always practice is the key. Practice your ABGs. And whenever you're getting the respiratory scenario, calculate AA gradient. If it is rise, mention rise. If it is a metabolic component, calculate anion gap, delta gap, and if there is any secondary acid-base disorder, you need to mention that also. So what are your next immediate treatment priorities? We can see the patient is hypoxic in this case, and he is a bit tachypnic, and even with HFNC, his oxygen levels are low, and there is a poor cough and gag reflex, so which might threaten the airway. So in this case, the immediate treatment priorities would be like assessment for airway breathing circulation, and please do not say ABC in your exam. Please always mention airway breathing circulation, and if it's threatened, the secure the airway. And oxygen supplementation aiming with the saturation of more than 94%, and simultaneously evaluate for the differentials of hypoxemia. So what is your differential diagnosis in this case? It could be a possible case or instead of differential diagnosis, when it is most likely clear, you can ask about the provisional diagnosis also. So in this case, the Guillain-Barré syndrome, botulism, acute myelitis, or thick paralysis. So coming with the acute progressive in lower limb weakness with respiratory failures, the few differentials, always answer your differentials in a structured manner. Either go by systemic wise if it's a systemic, or you go from top to bottom. Always structure your answer. You can prepare your answers beforehand. You can think that you can answer, you can tell the answer in a structure where during exam. No, you can't do that in that little amount of time. Always start your preparation in your structure way. While doing practice also, make sure that you practice yourself in a structured way and answer in that structured form. Always practice is the key. So coming to the differential diagnosis with acute progressive lower limb weakness and respiratory failure, I'm coming from top to bottom. So first will be the neuromuscular junction disorders like Guillain-Barré syndrome, myasthenia gravis, Lambert-Eaton syndrome, and peripheral nerve disorders. It will be like acute inflammatory demyelinating polyneuropathy, AIDP. That's the most common form of GBS, or acute motor axonal or motor sensory axonal neuropathy, toxic neuropathies in case of OP poisonings or heavy metal poisonings, critical illness polyneuropathy, though it's usually seen in the IC case. I've just mentioned it here for differential diagnosis. Spinal cord disorders, they may present as a weakness with the sensory changes and autonomic changes. If there is involvement of high cervical lesions, then we can see a part of respiratory failure. Or other disorders like transverse myelitis, spinal cord compression, acute ischemic myelopathy, epidural abscess. And muscle disorders like acute myositis, viral or autoimmune, toxic, polymyositis or dermatomyositis, rhabdomyolysis, critical illness myopathy. Anterior horn cell disorders, acute poliomyelitis or enterovirus infection, West Nile virus flaccid paralysis, neuromuscular toxins like botulism, snakebite, or tick paralysis. And, there can be a list of metabolic causes also like severe hypo or hypokalemic periodic paralysis or severe hypophosphatemia or porphyric neuropathy. So going on further with the case, how would you like to further evaluate the case? Whenever you say further evaluation or management, do remember that there will always be the investigation part and there will always be the treatment part. And with investigations, always come in a format where like blood or any other fluid analysis or imaging part. Okay. The first further evaluation of this case would be the complete neurological examination and bedside negative inspirator force or vital capacity monitoring. And coming to the investigations part, blood investigations like serum electrolytes or phosphate, magnesium levels, or heavy metal poisonings in case of suspected poisonings, creatinine kinase, thyroid function tests, or inflammatory markers. As he is having a preceding history of diarrhea and respiratory illness, Campylobacter serology or respiratory viral PCR and stool PCR. And CSF with albino-cytological dissociation can be there, and others like nerve conduction studies, EMG or MRI spine and chest X-ray. So coming to the next vignette, he was subsequently intubated and commenced on invasive mechanical ventilation. CSF analysis was performed and the results are shown below. The CSF protein is like A60 with a reference normal range of 15 to 45, and the CSF total leukocyte count is 8, whereas the normal is 0 to 5. In most of the EDIC exams, the abnormal values will be highlighted whether it is given in Most of the times it will be given as red in color, or they'll just highlight the values, abnormal values. So what are the tests you like to order? We can order the nerve conduction studies or EMG or autoantibodies and MRI spine with contrast. So they have concluded with the diagnosis of GBS, and they have started IVIG. They can give a question set of questions like how will you further evaluate, or how they have concluded with the diagnosis and how you treat that case, or they'll give an option of IVIG or Plex in this case, which one to start first or which can be better. They can ask you like what is the prescription, like they can go on with the further questions. So IVIG was started in this case. What is the dose of IVIG? It's 4.4 mg per kg gram per day or for 5 days, or 2 gram per kg over 5 days. So what are the possible complications or adverse effects? Fever, chills, thromboembolism, renal failure, arrhythmia, stroke, anaphylaxis. So what are the other treatment options available? In this case would be the Plex. So they can give you, there's they have started IVIG or they have gone for decision of Plex. So they can ask you about how will you prescribe Plex. So with Plex, the prescription will be like first with any modality like the vascular access and how much dose or what are the plasma exchange volumes and over how many duration or how many days you want to continue. So you can ask those questions also. So on day 14, he was still requiring ventilator support. Percutaneous tracheostomy was performed with controlled mode of ventilation in view of insufficient respiratory efforts. So in this case, they have said that they have already performed percutaneous tracheostomy. So they can ask you why they have gone for percutaneous tracheostomy, why not surgical, or pros and cons of each technique. Or they can ask you like because of continuous ventilator support, what further steps will you take, what are the procedures you can do, like that you can be asked. Sorry. So what are the pros and cons of percutaneous tracheostomy over surgical tracheostomy in this patient? It is a bedside technique. There is less bleeding risk, there is a short procedure time, and if cons will be the like difficult anatomy or posterior wall injury. And whenever you're given a case scenario, usually they'll mention about the age, height, or weight with the respective cases. Like in ARDS, they'll usually give you the height and weight so that you can calculate the predicted body weight or ideal body weight to say how much ventilation you can keep. Or in case of this case, they can give you a morbid case. In those cases, percutaneous tracheostomy will be difficult. So in those cases, you can go for surgical tracheostomy. But in this case, as I remember, it's given as normal patient only, not obese as per weight. So they have performed the percutaneous tracheostomy and they have asked about the pros and cons. So after tracheostomy, what is your next management plan? So winning from the ventilator support and supportive care like DVT prophylaxis, as it will be bed bound and pressure so prevention. In GBS, usually there will be neuropathic pain, so there has to be pain management, and we can expect autonomic this instability and the physiotherapy. So they have treated the GBS case with IVIG. They have in view of prolonged need for mechanical ventilation or respiratory supports with two gag reflex. They have performed the tracheostomy. And how will you assess for weaning? And weaning as such is a very important topic. So whenever you asked a question about weaning, make sure when to start and how to start. Okay. So how to assess for weaning readiness? First, clinical stability. Hemodynamically stable with no minimal or vasopressor support, febrile or mild fever, and awake enough to answer the questions. Like a respiratory muscle strength, vital capacity with more than 10 to 15 ml per kg, or negative inspiratory force more than -20 to -30 water. Maximum expiratory pressure of more than 40 centimeters water, and effective cough. To assess gas exchange adequacy, like SpO2 maintaining more than 94% on low support, or PaO2 of more than 60 on FaO2 of less than 4.4. Sorry. pH more than 7.35 without rising carbon dioxide during spontaneous breathing time. And neuromuscular recovery, improving limb and respiratory muscle strength, improved bulbar function, better trunk control for physiotherapy. Secretions, the secretion should be low, or he should be able to clear his own secretion with the proper cough or assisted cough and no active pneumonia. Spontaneous breathing tell, first we can start with the pressure support mode or triple styles. Initially we need to start with low duration and we can progress up to 2 to 4 hours, maximum 6 to 8 hours. While during spontaneous breathing tell, there should be no tachypnea or distress or no tachycardia or diaphoresis or desaturation, and there should be no CO2 reduction. In multidisciplinary review, we need to do a proper physiotherapy with speech assessment and bulbar swallowing or gag reflexes and autonomic issues also. Decannulation at this stage, of course, which is not at this point in this case, but at the later stage, you need to see. The patient should be able to maintain sustained spontaneous breathing for more than 24 to 48 hours with adequate cough and secretions control and the ability to swallow and with appropriate performance of the lead test. So in this case, on day 30, he was still requiring ventilator support, and the family was concerned about the prognosis. So in most out of the three cases, in at least one case, you'll be asked about the brain death or ethics or end of life care. So those are the topics you need to know. Though there are some boring and they are not that much, you may not recall, but if you go through it properly, they are most fetching topics. So how do you counsel the family? In this case, explain the diagnosis and expected course. You need to describe the GBS, so in its typical course that limb weakness may progress continuously before it start improving, and discuss the need of ICU care with the patient attendants, like emphasize with close emphasis on close monitoring and respiratory support and the treatment plan, and set realistic expectations. You need to assure the family that recovery may take from weeks to months, but most patients improve without any disruptions, but the recovery is slow. And offer emotional support, like and make them involved and encourage them attendants to ask questions to and clarify their doubts and provide reassurance and update them regularly about the changes in patient's condition. And how do you prognosticate the family? You need to honest but in a optimistic way. So overall recovery is likely but slow. Early severity guides the prognosis, and treatment improves outcomes and monitor for long-term deficits. So there ends our first case. Coming to the next case, a 19-year-old pregnant woman with no significant past history was admitted to the ICU with hemodynamic instability. She was intubated, sedated, and requiring FiO2 of 100% with a saturation of 83%. On arrival, her vitals are like heart rate 100 beats per minute, systolic blood pressure was 74, on noradrenaline support 0.3 mg per kg per minute, and temperature was 34.1 degrees Celsius. She has been admitted the previous day to the antenatal ward with fever and genital pain. An emergency cesarean section was performed for fetal distress. Postoperatively, she developed hypotension, cold peripheries, anuria, and worsening respiratory failure. Ventilator settings were like FiO2 of 100%, PIP of 12, tidal volume of 460 ml, and respiratory rate of 18 per minute. Examination were like pupils are sluggishly reacting to light, bilateral forced respiration was present, and there is a marked edema of the right labia. Coming to the lab values, ABG pH of 6.95, PCO2 of 42, PO2 of 64, bicarb is 9.2, lactates is 15, sodium is 139, potassium is 4.7, chloride is 100, glucose is 25 mg per dl, and hemoglobin is 13.9. Total leukocyte count was 23,600. Platelets were like 19,000. APTT 65. INR of 2.5. Fibrinogen 20 mg per year. Creatinine 2.2. Urea 61. Bilirubin of 22.8. SGOT of 259. SGPT of 220. LDH of 4095. D dimer of 3000. And CRP is 290. though I have not mentioned any X-rays or ECGs in this case scenarios, you can be shown X-rays and interpret the findings along with these laboratory values. You can ask questions regarding the same also. So as with any first questions with all the scenarios, summarize the case. So this will be the pregnant woman with the sepsis with septic shock and multi-organ dysfunction, probably secondary to the necrotizing fasciitis of labia, and complicated by the acute kidney injury, disseminated intravascular coagulation, and liver dysfunction. So, what are your positive findings from the labs? It is a consumptive coagulopathy with severe thrombocytopenia, acute kidney injury, and shock liver. And again, coming to the ABG interpretation, it is there is a severe metabolic acidosis with incomplete respiratory compensation. So, what are your immediate treatment priorities? You can you need to be in a realistic. You need to feel that the case is right in front of you. Then only you can answer prompt accurately. So, whenever the case getting shifted to ICU with somewhere intubated somewhere else, first when there is a hypoxia, instead of 100 FIO to 100, first of all, we will try to confirm with the ET tube position. So, in this case, confirm ET tube position, and we can say there is a hypoglycemia, correct hypoglycemia, and the NORAD is in the zero point 0.3 mics per kg per minute. According to the guidelines, we need to have vasopressin infusion to maintain BP targets or MAP. Ensure optimal ventilator settings with lung protective ventilation and low tidal volume ventilation. Optimal PEP and to keep diving pressures less than 50 centimeters of water. And it's clearly a septic shock. So start on empirical antibiotics, and she is mentioned as an anuric, so we can simultaneously plan to start in renal replacement therapy. So what are your differential diagnosis? It could be a case of necrotizing fasciitis or toxic shock syndrome, postpartum sepsis, amniotic fluid embolism, and PPH or a disseminated intravascular coagulation. So whenever you're saying differential diagnosis, make sure that whatever the differential diagnosis you're saying, it should fit into the case scenario. Don't just say whatever you read in the book. Be specific and be precise. So how do you further manage the case? We need to seek urgent surgical consultation for necrotizing fasciitis, and as it is part of the cause of the sepsis, we need to source control. For the management, I always remember diagnostic workup and the treatment plan. Don't forget that, please. So investigations, again coming to the investigations, precise manner, like investigations in the form of blood or imaging or any fluid analysis. In the investigations part, we need to, as we have already sent the routines like complete blood picture with the RFTs and LFTs. So other investigations would be like to send the blood cultures, urine. Though I mentioned sputum here, it's not sputum, it's AT culture, and swab culture from the infected area. And TEG or RTM, usually you'll be asked the questions about TEG or RTM. Definitely there will be questions, one in the CCS and one in the CVS. Though it's like it looks complicated, but once you read it properly and you understand it properly, TEG or RTM, it's definitely a scoring point once you understand it. You can answer it correctly once you understand. Please do read TEG or RTM for CBS and the CCS one. And explore a previous history of any multi-resistant organ infections or immunosuppression. And then when in investigations part, imaging, ultrasound abdomen or pelvis, or CT abdomen or pelvis. And coming to the next, immediate management will be like assess the fluid status with invasive hemodynamic monitoring and echo, and the correction of coagulopathy. So she was started on piperacillin, tazobactam, and vancomycin as empirically. She was taken to the operating room for sexual debridement, and tissue samples were sent for culture and sensitivity. The cultures have grown subsequently Peptococcus and Candida. They might give you a culture sensitivity report also, and based upon the area, you need to treat the organisms. If it is the Candida is growing in it, don't mention that you will treat with antifungals. So first of all, see where the organism is growing, whether it's a commensal or it is a pathogenic organism, and whether to treat it or not. So what are the next steps? Consider adding antifungal. In most of the cases, you can say which antifungal or which antibiotic you need to start rather than saying broad terms like beta lactams or like carbapenems. Instead of that, you can say directly whatever you want to add. And whenever you say antibiotic, please do mention the loading dose and the maintenance dose. So in this case, consider adding antifungal and idilafungin, or we can stop vancomycin, and after getting culture sensitive reports, we can de-escalate and keep the proper antibiotic. And whenever you are saying antibiotics, and whenever you are preparing to start antibiotics, so please do mention according to the local antibiotic. So antibiotics were escalated to meropenem, vancomycin, and clindamycin in this case. And what are the factors that can affect effectiveness of the antibiotics? She is hypoperfuse, she is in shock, and there is altered metabolism and clearance in this case, like AKA and liver dysfunction is also there. So they might affect the effectiveness of the antibiotics and availability. So in this case, there will be hypoperfusion, we are causing the poor tissue penetration and altered tissue delivery, and there will be increased volume of distribution, and the AKA and liver dysfunction may uh, they'll cause the decreased clearance, and we need to adjust dose accordingly. So what is their and ventilator strategies? They might give you, if it's a ARDS case, they might give you simply an X-ray on with or without some other invasive lines or some other findings, and they may ask you about the findings also. So be prepared with the like basic things like ARDS, effusions, or pneumonia patches. So they will definitely give you an X-ray to read and interpret the X-ray also. So what is your ventilator strategies? In this case, the lung, we should go ahead with lung protective ventilation, low tidal volume ventilation, and keep the P plus less than 30 centimeters of water with adequate sedation. If not required, paralysis also, and consider proning if the F ratios are low, and titrate FiO2 to maintain PaO2 of more than 65, and allow permissive hyperpnea with a pH more than 7.25. So again, they have done the repeat ABG. The recent ABG was like pH of 7.0, PCO2 was 36, PO2 was 66, and bicarb is 89. You can see there is an improvement of acidosis a little bit, though there is a significant acidosis and PCO2 retention with the given bicarb. So how will you further manage? Or they can ask you again about the ABG interpretation. So what are the other modifications you can suggest? As you can see, there is a carbon dioxide retention. We need to increase the minute ventilation and increase air respiratory rate. And if the platelets are going higher, we need to reduce the tidal volume. And how will you manage refractory hypoxia? In this case, the optimized PEEP or consider proning with adequate sedation, if required paralysis also, and refer to titration and PEEP titration and restricted fluid strategy. So whenever you are given a case, mostly you can get a case of ARDS or pneumonia also. So whenever you get a case, make sure you answer accurately with the like lung protective ventilation. There are few points which sirs, Tapar sir and Sanan sir and Jitendra sir have explained ARDS very nicely in the TRICS course. They have given very few points, but very important points that will score you the maximum. So on invasive cardiac output monitoring, the findings were attached like the cardiac output is 6.8, cardiac index is 4.2, stroke volume is 60, and the SVB is like 6. So they can ask you about the other parameters also, and they can give you other parameters and interpret your findings. So invasive hemodynamic monitoring, at least, and usually they'll give you the abnormal normal values also, so that you can say whether it's high or low, and based upon that you can come to a conclusion whether what is needed. So what is your interpretation from the above findings? It is more looking like a distributor shock with a SVP less than 6%. It's not, she's not fluid responsive. So how will you further proceed? We have already continued with the injection or adrenaline and vasopressin support, and we can start injection hydrocortisone also as a part of suppression. Despite fluid resuscitation and vasopressors, he is still anuric, and with the given ABG, how will you manage further? So, you can say we like to start with renal replacement therapy in your correction of acidosis, and we need to avoid nephrotoxic as he is going into AK, and adjust antibiotic dose according to the renal clearance. So, whenever if you asked about the renal replacement therapy, make sure remember the case scenario and answer like whether it's you need a continuous modality or an intermittent modality. Read about the absolute and relative indications. We all know whether to start the continuous and the intermittent modalities. And if you're asked about renal replacement therapy, and they might ask you about the prescription of renal replacement therapy also, like you need to start with the vascular access and which modality you want to use, what type in case of continuous or intermittent, which modality, and what are the flows you need to set, and what are the targets you aimed at reaching. So those are all also can be asked. So after initiating renal replacement therapy, her acidosis has begun to improve and vasopressor requirements are steadily decreasing. So at this point, will you start enteral nutrition, or whether they can ask you about, they'll give you a particular dose of noradrenaline. They can ask you whether you can start enteral nutrition or not, or if you want to start, how will you start? Like that, the questions can be framed. So in this case, how will you start enteral nutrition? It could be nasogastric to nasogastric tube feeding, enteral nutrition with only trophipids as she is in septic shock, and vasopressor support. And after starting pills, look for intolerance. If there is intolerance, add prokinetics like metoclopramide, erythromycin if needed, and look for refeeding syndromes. Avoid full feeds if the noradrenaline is more than 0.3 mics per kg per minute. So with that, we have concluded the second case. And coming to the next case scenario, a 68-year-old man is on post-op day 1 following elective CABG for 3 grafts, Lima to LAD, SVG to OM1 RCA for triple-vessel coronary crisis. His medical history includes hypertension and type 2 diabetes mellitus. Intraoperative findings like bypass time is 112 minutes and cross clamp time is 76 minutes. Whenever you get a CABG case, please do know about the normal timings of bypass time or cross clamp times, and what are the possible expected complications with immediate post-op and early post-op, and during CBP also. And if you get the CBP case, you can ask about the TEG and bottom findings also. He is experiencing recurrent episodes of atrial fibrillation with fast ventricular rates of heart rates around 140 to 150, followed by sudden sinus pause, leading to lasting up to 6 seconds, and they are causing pre-syncope and hypotension. On examination, the findings were like with oxygen of 4 liters per minute with nasal cannula, the saturation is 95%, respiratory rate is 22 per minute. There is a bilateral reduced sounds on both sides of the lungs. The blood pressure is fluctuating in between 85 by 50 to 110 by 70. And the heart rate of rhythm is irregular with intermittent leave sinus pauses and rarely with up to 35 beats per minute. And the JVP is mildly elevated. The chest rates are showing 50 ml per hour with 0 sign minus. The pacing wise, the temporary pacing wise are in situ. And the GCS state, neurological status is like GCS 15 by 15. Intermittent episodes of dizziness were also there during bradycardia episodes. The temperature was like 37.9 degrees Celsius. And the surgical state, there is a sternotomy sutures with the dressing, and they are clean and intact. In this case, they might given an ECG rhythm strip also, or they can simply say the ECG was showing AF. Otherwise, they can give you an ECG rhythm strip and tell them to interpret the ECG also. So from investigations part is ECG here, it's showing AF with FVR and with alternative junctional brady and sinus pauses. Hemoglobin is like 8.4, TLC was like 14,000. Potassium is 3.3, magnesium is 0.65. Creatinine is 160, troponin is mildly elevated, but it is down trending. A chest X-ray showing bilateral atelectasis with left pleural effusion and mediastinal drains and pacing wise correctly positioned. Or echocardiograph, the EF is like 40% with mild RV dysfunction and no features of pericardial damage. In this case, the probable questions could be like they can give you a ECG rhythm strip or they can give you a proper ECG, valid ECG, and then they can ask you about the ECG interpretation, or they can give you a echo findings with the pericardial effusion or tamponade features, or they can give you a chest X-ray with the drains or misplaced drains or pneumothorax or effusions or with the pericardial effusion. So they can give you those images and they might ask you to interpret them also. So in this case, do you summarize or interpret your findings? There is a significant arrhythmia with instability, like with tachybrady syndrome, like AF bradycardia, causing episodes of hypertension. And there is a hypokalemia and hypomagnesemia, probably contributed to arrhythmias in this case. And the post of myocardial dysfunction is low, and there is a mild RV impairment. Usually, they'll give a pre-op and post-op status. If they're not, we can assume that it's significantly decreased. And there is a mild troponin rise consistent with the perioperative myocardial injuries and chest X-ray abnormalities like atelectasis was there, effusion. Both can be post-op status, reducing respiratory drive. So what are your differentials? It could be a case of sick sinus with tachycardia syndrome, which has been as masked post-operatively, or the electrolyte imbalance causing the arrhythmias like hypokalemia or hypomagnesemia, or there could be case of post-op myocardial ischemia and stunning. Usually, with TVD cases, he can be on pre-op beta blockers or amiodarone antiarrhythmics and other anesthesia. Those drugs could have not been cleared systemically, leading to their side effects or prolonged effects, and pericardial effusion or tamponade causing electrical instability and hypertension. So, how will you further manage this case? First of all, you need to assess the case, what type of shock, and address the airway breathing circulation. And there is a significant hypomagnesemia and hypokalemia in this case, so we need to correct like supplementing by IV replacement of potassium and magnesium, and to keep the values more than 4 and more than 1. Manage a atrial fibrillation with hemodynamic instability. In some cases, you might ask about which is preferred in acute settings, which why and why, uh, or is there any place of cardioversion without hemodynamic stability. So we can ask about everything as improper also. And prepare for pacing, and as this case has already epicadial wise transpacing in situ, we can go for pacing. So, if you get a question about the pacemakers, they can ask you, like there are only few questions they'll be asking most of the times. So it will be like, how will you name, so what, how would you prescribe a pacemaker, like how would you set the pacemaker, and they'll ask you about the sensitivity triggers, or thresholds, or captures, or they can give you a rhythm strip with uh, like there with loss of beats or loss of capturing and decreased sensitivity. So they can give you a ECG rhythm strip and with the pacemaker in situ, and they'll ask you about the what is the abnormality find and how will you further correct or further evaluate this case. So in this case, how will you set the pacemaker and decide on the intervention, like whether immediate temporary pacemaking by epicardial device, and how will you set? Usually, we'll set with the DDD or BVI mode based on the availability of pacemaking device, and determine sensing threshold. Uh, so first, after determining sensing threshold, you need to keep the sensitivity half of it, and determine the capture threshold, and keep the price of that value. So coming to the pacemaker nomenclature, like usually we'll be reading with 3 letters. The first letter usually will be the chamber space. It can be atrial, ventricle, or the dual chambers. And second letter is usually the chamber sensed with the atrial, ventricle, or dual or one. And third letter will be like response to the sensing pattern, like whether it is going to inhibit the heart or trigger the heart or dual or not. So coming to a few nomenclature like sensing threshold and pacing threshold. First, sensing threshold, how will you start? you need to set the sensitivity knobs to the maximum level and the pacemaker and set the pacing rate to below the patient heart rate. As you come down on the sensitivity level, watch for the pacing spikes to appear on the monitor, and when the pacing starts, the flashing light will stop. So at this point, you take that as sensor threshold and set the number double at this threshold. So pacing threshold, increase the rate to just above the patient rates and slowly increase the output until pacing spikes appear and capture occur. When the pacing threshold is liquid, for safety purpose, it is usually kept at double this threshold, so that if the pacemaker wants out, so that you don't get the pacemaker failure. So what are the other investigation or interventions you will consider along with pacing? As we can see, he's getting episodes of brady, so hold amiodarone if it's contributing to brady episode. And as we already have pacemaker, usually we don't get a problem with the pacing or not capturing. If the problem occurs, we'll consider adding the chronotropic support for a meanwhile and evaluate the need for pacemaker, permanent pacemaker, if it is persistent for more than 5 to 7 days. And they might ask you about the why what conditions has led to this tachycardia syndrome post CABG, like surgical manipulation of the heavy and descent nodes or ischemia or perioperative amiodarone or electrolyte imbalances or pre-existing condition that has got unmasked after the surgery. And when to consider permanent pacemaker, if you get a question about the permanent pacemaker or ICDs or defibrillators, you'll get what are the indications and and their specifics also. Like in this case, when to consider permanent pacemaker, if the body arrhythmia persists for more than 5 to 7 days, or if intrinsic conduction doesn't recover, or recurrent symptomatic causes despite correction of reversible values causes. So what are the other complications are you monitoring for in this case? Probably because he's having AF with Brady, there always a possibility of stroke from atrial fibrillation or post-op complications like pericardial tamponade or graft failure post-pump CES response, arrhythmias due to electrolyte imbalances or AKI progression and hospital-acquired infection. So that concludes our case. Coming to the next case, a 36-year-old man with poorly controlled HIV who is on irregular antiretroviral therapy, and the last CD4 counts were like 68 per microliter, underwent emergency laparotomy for jejunal perforation with purulent peritonitis, likely secondary to CMV enteritis. A small segment of small bowel dissection with primary anastomosis were performed. Now he is in the ICU with deteriorating status with persistent high-grade fevers, worsening cytopenias, escalating vasopressor requirement, altered mental status, and progressive organ dysfunction. Findings raise concern for secondary HLH and sepsis-related non or uncontrolled intra-abdominal cases infections. So here I have kept the diagnosis here in first case scenario. Usually it will not be like that. Most of the clues will be there, so you can instantly pick them up. So on examination, the findings were like a temperature of 39.5 degrees Celsius. BP is like 88 by 50 or not at 0.2 mics per kg per minute. Heart rate is 124 per minute. Saturation of 94% on FiO2 of 0.4. Bone pressure support move. Respirator was 28 per minute. GCS is like E3 and 4, B5, confused and agitated at times. But full perfusion with warm extremities when morphine lower limbs and capillary filling time of 4 seconds. Chest examination, bilateral post, crackles, all that. Abdomen post-op wound is clean with mild hepatosplenomegaly. In investigations coming to the investigation, hemoglobin is like 7.8. WBC count was like 1.2, and platelets were like 52,000. Ferritin is 34,500. Triglycerides were elevated. Fibrinogen is low. CRP is moderately elevated. LDH was high. AST and ALT were also elevated. there is a rising levels of urea and creatinine. Here they might give you a chest X-ray or CT abdomen with the positive findings. You can be asked like what are the CT findings or what are the chest X-ray findings, and interpret the values. So here you have mentioned as a chest X-ray diffuse interstitial infiltrates showing infection or ARDS or immune-driven lung disease. Abdominal ultrasound mild hepatosplenomegaly or no new collections were there from the previous findings. Intraoperative findings were like 1.5 centimeter jejunal perforation with purulent peritonitis and segmental resection and primary anastomosis were done. They have also noticed mesenteric lymphadenopathy, and they have sent the cultures of the peritoneal fluid. The cultures have grown gram negative rods, and here they can give you a slide of gram staining, and they might you might get asked what about the positive findings and what could be the possible organisms and what could be the possible like how will you treat, like antibiotics needed to cover those organisms, like that you can also get asked. So in this case I interpret the findings. There's a persistent high grade fever suggest an ongoing severe infection or hyperinflated state, and progressive cytopenias like low hemoglobin, WBC scan, and platelets indicating bone marrow suppression or HLH. Very high ferritin values is highly strongly suggestive of secondary HLH. And low fibrinogen, high triglycerides further support the HLH physiology. And elevated like a dehydrogenase and LFTs indicating tissue injury and multi-organ dysfunction. There is a worsening AKI and requiring vasopressor rising supports signify escalating shock and systemic inflammation. So, what are the other differentials we like to consider in this case? Though they have given a secondary HLH, what could be the other possible causes? So it could be severe sepsis with septic shock, or as is a retroviral disease with low CD4 counts and not a proper ART, regular ART. He can have immune reconstruction primitive syndrome, or he can have genetic infections or drug-induced bone marrow suppression or HIV-associated immune dysregulation. So you can get asked about so on what basis you have concluded that he's having the HLH. So you can get asked about the HLH criteria or what are the diagnostic criteria. So for diagnosis of HLH, so diagnostic criteria of HLH, it's a molecular diagnosis consistent with HLH is present. Or if there are more than 5 out of 8 criteria, the criteria were like fever, temperature more than 38.5 degrees Celsius, and it should be persistent. Splenomegaly on imaging or examination. The cytopenias with more than 2 out of 3 cell lines with values less than H, hemoglobin less than 9 gram per deciliter, platelet less than 1 lakh, and neutrophils less than 1000. There should be hypertriglyceridemia or hyperfibrinogenemia. The values of triglycerides should be more than 265, and there should be a fasting levels and fibrinogen less than or equal to 1.5 gram per liter. And there should be hemophagocytosis on smear, like this is demonstrated on bone marrow, spleen, or lymph nodes and liver, and, and low or absent NK cell activity below lab references, and ferritin elevation, which is usually more than 500 nanograms per ml, and elevated IL-2 receptors. So, what are the if you get a case of HLS, they can ask you. In this case, I have shown you like a infection causing the secondary HLH, but you can also get a case of primary HLH, and you can ask what is like what are your treatment management options, like that. So, what infectious commonly trigger HLH in these cases? It's like CMV infection or EBV or mycobacterial or fungal infection and or disseminated bacterial sepsis. What post-operative factors can increase is major systemic inflammatory response, surgical stress or tissue injury, peritonitis or intraabdominal sepsis, or interruption of ART leading to viral load. So how will you manage the case of HLH? You need to give heavy dexamethasone, and whenever you are saying some drugs, you need to mention dose, specific dose and duration also. For HLH, it's very particular. like how much dexamethasone and how much etoposide you need to give. So in this case, how will you manage? You will start treating with IV dexamethasone, etoposide, and treatment of the precipitating factors like infection in this case. So this is the chart. How will you manage? So first we need to start ART in this case, so like ART in this case, and treat CBV, CMV or EBV infection with ganciclovir. And with dexamethasone, what does it do? It reduces the cytokine storm and organ failure. How will you start and what is the dose prescription? It's like 10 mg per meter square per minute for on week 1 and taper it over the 8 weeks according to HLH 94 protocol. And for etoposide, in case of primary or fulminant organ failure, life-threatening HLH, we need to start with the doses of 50 mg per meter square. It should be given as twice weekly for 2 weeks and then weekly. And next is the cyclosporine A, 6 mg per kg per day. It should be added from the second week. And IVAG, it is used usually in case of infection triggered HLH. Dose is like 2 gram per kg. It should be given over 2 to 5 days. And while you're treating the HLH, you need to monitor the ferritin and triglyceride levels also, as to see the response. And what are the further rescue or severe in case rescue therapies in case of severe or refractory, and a IL-1 blocker or ruxolitinib immopilimab. The doses you can see like 2 to 10 mg per kg per day of subcutaneous or IV, or 5 to 10 mg per 10 mg BD. And in case of, as I said, this is a case of secondary infectious. So in case of primary, what are the how will you like how will you treat further? So in those cases, in case of primary, we need to do stem cell transplant, and we need to consider steroid or etoposide in case of refractory cases. So this concludes my session.
Thank you, Dr. Susmita, for
Yes.
sharing your knowledge as well as also describing the questions, the domains those were asked in the last EDIC 2 exam. So anything from the candidates you can post in the chat box, or else we'll be seeking help from our other faculties, Dr. Jitendra or Dr. Sakshi, if you want to share anything. She has nicely covered
Yes.
all the 3 CCS.
Yes, sir. I just wanted to share that they were very focused on all scoring systems. They kept asking, and they also asked for me in the GBS system. They asked me picks, which was covered in the TRICS classes in my mock exam, and they were very focused on taking cross references, taking surgical references, hemat references. What are the scoring systems in HLH? How will you differentiate? How will you prognosticate the family? How frequently will you talk to them? All these things they were focused on that a lot.
Yes, agree. Nowadays, it is more of like communication and how you are confident of like communicating to the family. They
Um,
would assess as you are the attending or you are going to be the attending in your hospital in your ICU. So this is one of the core domain they want to check.
Yes, so they have asked mostly like communication part in particular, like will you prognosticate, or whether it's a case of prognostication or communication, the ethics part. They have been very particular about it. They're at least adding a one question to each CCS in the last session.
Yes. Dr. Jitendra, anything?
Yes, sir. That's what, as Sushmita rightly said, you will be given adequate time after your initial case history. So in that meantime itself, you can frame your questions because you know what is expected. So you, like in the first thesis itself, you can plan. So this is a case of AFP, so you can plan what would be the differentials, how you manage. So you'll get adequate time. So you can usually frame most of the questions because there are some standard questions which will be asked in a particular case. So I think she rightly said, no need to hurry for the answers. You can just wait till the examiner asks for you. So otherwise, rightly said, and discussion, documentation, this will be expected in some part of the CCS, definitely will be asked. And brain death, organ harvesting, so all those will be asked for.
Yes, so Dr. Jitendra is right, and I would be highlighting that all of our Tricks 2 modules that normally covers the flow of the questions in the proper systematic way and also the structured answer. So if anybody has attended our introductory webinar before or some of our modules, those are available in YouTube. You must have seen that the modules contain exactly what is expected from the candidates in a very systematic way. Whatever you answer, but if it is short, succinct, and crisp, your the total marks are not that as you expect. So normally the candidates say that we have answered almost everything, but why the answer like no the marking or we are not passed. So this is something what is normally the feedback from the successful candidates, that you may answer it like in a short time, but yes, it has to contain everything that the examiner normally expects in a structured way and also in a very lucid way, because it should like no the examiner should feel that the words that you are using are music to the ears, that I can say. Sanand, anything if you are awake? I know it's almost
No, I
1
am awake. I am awake, Tapas. I mean, so you made the point. This is a specialist exam, or rather than people who are taking the exam are already specialists. So the expectation is like that. It is very um, clinical, yes, but paraclinical things will be asked. Like paraclinical things include communication, as Dr. Jitendra said, assessment of brain death, management of donor. Um, so these are not fellowship level questions. They will be asking about higher than fellowship level questions. Very focused on communication, even like how do you breaking the bad news, what are the steps in there, how will you arrange a meeting, and how do you set up a particular department in the ICU, for example organ donor department or research department. So these are the things you expect in this type of specialty exam. So they will be asking something extra compared to what usually asked in a MD or a MD exam or a DM exam. So this is the exam of higher than a specialist. So that should be the overview. When you see, as Dr. Jitendra was saying, you get adequate time after the case vignette. Always think out of the box. What are these questions will be? Definitely there will be clinical questions which you should guys able to answer. But those paraclinical questions you should be able to estimate that what they are going to ask based on the scenario. So that thing you have to develop, and that's what we focus on in these practice also.
And last but not the least, it is all the practice, because people they normally give the feedback that we know everything, but in the stipulated time we are unable to actually express ourselves or complete the whole answers. So that is something is not like no advisable, because if you know it, you have to answer it in those 25 minutes or so. And CCS compared to CBS is more mark fetching, so you should be very comfortable in like no passing the CCS station. Okay, perfect. So if there are no more questions, so I would request Dr. Jitendra to start with the CBS questions, and Dr. Sakshi has contributed to the questions. So I would also request her to participate in the discussion and also share the questions, the domains those were asked in the real exam.
Thank you, Professor. I would like to ask Sushmita and Sakshi, can you just tell the viewers how would be the exam? I mean, how many CBS questions, how much time you get to process and answer?
Sir,
So
in
after that, we'll go to
CVS,
the questions.
we got 12 minutes. There were three tables, 12 minutes to
Okay.
solve eight questions. So around 24 questions, so 36 minutes. And
Okay.
I didn't find, I thought the time was sufficient, and they were very, very relaxed. They were not trying to rush us, they were relaxed. And they kept asking anything else, like they would prompt. So what was my seniors had told me that if you're not sure, then you move to the next question and you ask to come back to the previous one. So then I got time to come back and then reflect on it
Mm-hmm.
again. And they were helpful. So they were not very strict or
Yeah.
very. They're not hurrying me. They were quite patient.
So
Okay.
Dr.
Anything,
Sakshi,
Sushmita, you want
maybe
to add? Oh,
Yes,
sorry, sir.
yeah, like usually they will be given ECG strips or ECG, like 12 ECGs, and the basic ventilator curves. Like usually there will be most of the time, repeated questions are not like repeated questions, like
Some
ineffective
standard questions.
triggering standard
Yes.
questions. Yeah,
So
and
Tapasya wanted to add
IABP
something.
curves. Yes, ICP curves. Like most of the time, it's like standard questions. And coming to the like images, most of the them we can say, but we need to say all the findings and we need to be very accurate about it.
yeah.
Tapasya
So
wanted to add something. Yeah.
yes, yes, yes. So I would say the two candidates from our academy, they are very lucky because there are a lot of feedbacks this time also because we have to be what has happened in the real edict too. So there are few candidates who have also shared their concern that they were not given adequate time and the examiners are actually not allowing to go back to the previous questions if they have left. So it varies from like maybe candidate to candidate, but yes, if you are confident enough and you go in a very systematic way, definitely the examiners are not harsh on any candidate and they would allow you to like at least revisit those questions if you have some of the time left behind. Yeah.
So without wasting much time, so
Yes.
we'll go to the questions. So as said, these are not the exact questions. So whatever the students could remember, that is what Dr. Sakshi shared with us. So I hope the slides are visible. And you can add anything, Sakshi or Sushmita, if that is, when it is something different from the question what you have prepared. So just we
Yes.
go through part of the questions and Tapas sir will do the part of it. So these are the questions. So as the slides visible,
Yeah, you can make it in the PowerPoint presentation
yes, sir.
also. Yeah.
Okay. I think this was the first question we had. So it was, sorry. It was a 17-year-old boy who was found in a public gathering, unconscious, tachypnic, and febrile. So his labs were sodium of 112, potassium 2.8, chloride 99, tachycardic with possible history of some drug abuse with amphetamines. So what is the likely diagnosis and what will your management be? So this looks to be some drug overdose or things like that. So it will be a toxidromic approach. So keeping with the history, it goes in favor of either amphetamine poisoning or cocaine poisoning is a possibility. So, or other differentials would be SSRIs, antipsychotics, and antiepileptics. And most of this, the management would be symptomatic or supportive care only. So, first you maintain the airway breathing circulation. And there is, usually there is a sympathetic storm. So, you manage the sympathetic storm. So, that is how it will be. So, I'm assuming this is the same question which all of you had got. Any toxidrome, it is a very scoring subject, and you do get differentials. If you have an antidote, mention the antidote. If you don't have the antidote, it will be specific supportive care. Okay, and go it by the systematic approach, by the toxidromic approach. Sorry, we missed the initial question. Sorry.
No,
So,
just to add on the toxidrome question, Dr. Jitendra.
yes,
So
sir.
the usual toxidromes, they normally European examiners are normally ask are SSRI, then TCA, unlike
Yes, sir.
the other the I would say
You
the
don't get OP
tropical country.
poisoning,
Yes,
rat
yes,
poisoning, all those won't be the regular things. So, usually it'll be one of these. That's why I added only these drugs.
yes.
I'll go to the first question. I'm sorry, I missed it. So, another one was a 23-year-old female who came with history of fever, glucose of 17, drowsy, confused. One second. Yeah, so drowsy, confused, and sodium of 122, potassium of 4 milliequivalents. So ABG was 7.21 pH, PCO2 of 28, PaO2 of 78, and bicarb of 14. So the question was, what will you do next? So I'm assuming this could be a case of metabolic acidosis, mostly diabetic ketoacidosis, and there is still hyponatremia, and you should calculate the corrected hyponatremia. Potassium is okay. So if this is what the case is, then it should be diabetic ketoacidosis and its management. So usually it will be IV fluid resuscitation, insulin infusion. So, and no need to worry about the sodium part because that will get corrected once you correct your sodium and adequately resuscitate the patient.
So they
This was
specifically asked me to comment anything else. Then I said potassium
okay.
replacement. Then they said, okay, next.
Okay.
So they
Okay.
asked me potassium also. That's why I
That's what
mentioned the potassium at 4. Specifically, the potassium was 4 in the exam.
Okay. Usually it will be like you'll get a hypokalemia and high sugars.
Yes.
So they
Yes,
will
sir.
be expecting you to manage hypokalemia first and
Yes.
then the sugars. That is
Yes,
what
sir.
usually is expected. But as Tapas sir said, I think Sakshi, your examiner was very liberal. Usually you don't get any feedback from the examiners. That is what we have been seeing. And most of our other students also said that they did not have any feedback or did not have any adequate time. But you are pretty lucky actually. So going to the next question, it was a 19-year-old boy presented with one episode of seizure, history of fever, altered sensorium since 2 days. So if you see the CSF picture, it is glucose of 98 milligram per deciliter. Cells were normal. Protein was normal, which is 52 milligram per deciliter. Clear appearance, normal opening pressure. Basically, it's a case of altered sensorium, fever, seizure, and normal CSF. So if this is the complete details which is available, then it will go more in favor of some encephalopathy, like metabolic, maybe renal or hepatic. But still, we don't have complete history.
For this, he asked
Yeah.
me what is the likely diagnosis. So I said this is a young person. It could be herpetic. So they said, okay, what will be the treatment? So I said the full dose is cyclovitis. Then he said, okay, next. So he jumped to the next.
Okay. So that's what. So most likely, I mean, if the CSF picture is normal, usually it will be like a systemic cause, like metabolic encephalopathy, some toxins, drugs, things like that. But I don't
And
know if you have missed some details. Yeah.
I think, sir, I think I missed. I think proteins were slightly higher, if I'm not wrong. Proteins were slightly higher.
That's what. If
yeah,
it is, I
protein was
mean, this
little bit
whatever two,
higher.
little bit
Protein was
higher. So
higher.
then it will go in favor of some viral
Fabricated
picture.
also, but the presentation looked like herpetic. That's so he asked me the dose. So that's why.
So that's
And
what
some
must
of
be
the
some viral
times,
picture.
yes, and some
Yeah.
of the times, if we already gave the answer like with very short answers, if it is correct, and they are just jumping to the next question
Yes.
without us giving much explanation and without
Yes.
us giving much more answers. So if they
Okay.
get the answer, they are just moving on to the next question. As
Okay.
that
So even
what
I was
I have
expecting
observed.
some abnormality. I was at least expecting some proteins. I was thinking some terms
I
of
think, sir,
some
I
viral.
made a mistake, but proteins were
Okay. It's
slightly
okay. It's
high,
okay.
not very high,
Okay.
slightly high.
Okay. So that's what I mean. This picture is little difficult to say, but if it comes like this, it will be some systemic cause. So if it was purely CNS cause, you would have got some abnormality in the CSF definitely. So if it comes something like this, it will be a systemic cause, like any one of these is a possibility. So next one is a standard question. I think we have discussed in our modules also. This is a pretty common question. 45-year-old female rescued from fire, now drowsy, confused, resuscitated in the emergency room. No other major injuries or burns. So SpO2 was 85%. So this is standard case of, with lactates of 7 millimoles, PaO2 64 on room air, and PCO2 of 32. Bicarbonate was 24. Methemoglobinemia was 10. Saturation was 90%. What would be the likely pathology? Which test could you likely do to confirm in treatment? So this is a case of closed space burns. So inhalation injury, so methemoglobinemia because of the smoke inhalation. The test you do is co-oximetry. So management is oxygen, methyl blue, hyperbaric oxygen, and if it is refractory, even after that, you should consider exchange transfusion also. This is a pretty
Sir,
standard
also in
question.
this, he asked me anything else you want to add. So I said there could be cyanide toxicity also. So he said, okay, what is the treatment? Then I said hydroxycobalamine and other things.
Yeah.
So he said, okay, next. So then he jumped to the next thing.
Okay, that's a carbon monoxide poisoning is also.
Yes, and amyl nitrate. So before I could complete, he said, okay, and then he jumped. So.
Okay, yeah. So next is 17-year-old boy. This we have already discussed. So next is patient on CRT with complaints of tingling sensation in peripheries. Total ionized calcium is 2.5. So what is the cause and treatment? I think it is pretty easy question. So the case of hypocalcemia because of citrate overdose or cigarette toxicity. And management is calcium supplementation. So this is a pretty straightforward question. And this one, 42-year-old female received post-op from elective fist surgery. So intra-op the anesthetist noticed masseter tachycardia, and high temperature, 104 degree Fahrenheit. What is likely diagnosis and cause? I think you can also, whoever is from anesthesia background is a pretty common question. So this is a case of malignant hyperthermia. You see mesosclerosis, tachycardia, high temperatures in anesthetized patient. So it goes in favor of malignant hyperthermia. So either succinylcholine, halothane, one of the anesthetic agents is the probable cause. Management is with dantrolene, supportive care. So that is how it goes. And this ECG, this is an ECG of a 24-year-old male found unresponsive to music first. So this was ECG, and what is the finding and what will you do next? So I'm thinking this is hyperkalemia, but doesn't go with the history. Maybe we
Yes, sir.
might have a
This
little
was
more about.
because the history was more that this patient was hyperactive. Like they
Okay.
were jumping, like maybe a drug
Okay.
overdose. That actually threw me
Okay.
off, because when he mentioned that there was some, I was not able to frame the question that accurately. But when they
Okay.
mentioned that there was some drug congestion, so I kept on
Okay.
focusing on AVR, because I
Okay.
thought
Okay.
drugs. I completely, I saw the hyperkalemia, but I was focused on
Okay.
AVR. So I said I will
Okay.
send talk screen after I address this thing. Then he
Okay.
kept asking me, what else do you see? What else will you do? Then I picked it up. Then I was able to answer. But because there was
Okay.
a mention of drugs, so I kept looking
Mhm.
at AVR, which was
Okay.
wrong.
Okay. Okay. So that's what I think still it goes with hyperkalemia. That's what it is
Yes,
a possibility. If they say some drug history is there. Something
yes,
like
sir.
even cocaine can present with some changes like
Yes,
this and all. So, but still, if you go with the simple history and classic ECG findings and all, hyperkalemias are possible. But hyperacute T waves, if you think it can be myocardial ischemia in a male suddenly found unresponsive, is also a possibility.
mm,
So that's all. It may not be the exact ECG as Dr.
yes,
Sakshi says. So we don't know
mm,
what exactly was there. So either it will be hyperacute T waves or most classically it should be hyperkalemia. I think we would have had little more history. So
yes, sir.
say hyperactive patient, so some rhabdomyolysis,
Yes, sir.
hyperkalemia, that could also be a possibility. So I think it is hyperkalemia and management of hyperkalemia. Like in this case, first you should give calcium gluconate to stabilize the heart, and then measures to reduce the potassium levels like insulin dextrose, salbutamol, furosemide, sodium bicarbonate, and your binders. And if it is life-threatening, so you can consider dialysis also. And this is another, as said, waveforms. You get all the waveforms, CVP waveform, ECGs, your ABP waveforms, ICP waveforms. So all these are very, I mean, you can expect a question, no doubt or doubt. Even your ventilator graphics are all expected questions. So this was one of the questions which was asked in the recent exam. So they had given a waveform and they asked you what are the parts of the ABP. So I've just put the image here. And so this is 1:1. If I mean 1:2 ABP support. So in this you can see your A is your unassisted systole, B is the point of balloon inflation or the dicrotic notch where your aortic valve is closing and that is where your balloon is inflating. So B is point of balloon inflation. C is where you have the diastolic augmentation. D is your assisted aortic end diastolic pressure, and finally E is the assisted systole. So this is the labeling of your IBP, and they'll definitely ask you some troubleshooting, and
Mm.
definitely will have early inflation, late inflation. One of those characteristically will definitely be asked from the IBP. This was another picture. So 68-year-old homeless man found in the park, unresponsive. Temperature was 26 degrees Celsius. So from the history itself, it is very obvious this case of hypothermia. And they're asked you to identify the findings in the ECG. So you can all see the stars represent the Osborne waves where there's J point elevation. So this is a case of hypothermia with Osborne waves. And what is the management is rewarming the patient, how you rewarm, either passive external rewarming or active rewarming. So, and any of these, and if it is refractory after this or very severe hypothermia and your patient is in very critical condition, you can consider even extracorporeal warming devices are also a possibility.
Sir, in
Yes.
this case, so this is
Yeah.
not the exact ECG. The exact ECG
Okay.
had first degree AV block with sinus bradycardia with Osborne waves. So once I
Okay.
addressed the Osborne wave and the rewarming and everything, they still asked
Mm-hmm.
me, "Do you see
Okay.
anything
What are
else?"
the findings? Yeah.
Then
Okay.
I
Okay.
told them that okay, there is this
Mm-hmm.
also. This is when I came back to the ECG. So then
And
they,
Mm-hmm. Okay.
they were able to, like, they told me that look at it again. So
Okay.
and
they
I
gave
think there is also QT prolongation is there in
Mm.
that ECG
So
with the
whenever you
first
get an
degree.
ECG, so if it is not
So they
very
are asking
obvious, you
the
can
whole
start with
findings. Yes.
yes,
yeah,
Yes.
yeah. So you can start with interpreting the ECG. So this is the
yes,
case. So this is the rate. So you'll get some time also, and that will make. I mean, you would have covered most of the findings in the ECG also. So
yes,
don't just stop with the highlighted point. So you can just. I mean, it will not be marked star like this in your exam. So you can just. I mean, you can interpret the entire ECG without leaving anything, so that it will complete your answer also, and it will make your ECG interpretation also easy. You will not miss anything if you do it like that. This is another ECG which was there. So describe the ECG and treatment. So this is a case of a sinus rhythm ending up in torsade pointers, correct? So with the
yes.
preceding QT interval, you can see the QT interval is prolonged and gradually it had end up in torsade pointers and again it becomes sinus at the end of the rhythm. So, I mean, what is the management is defibrillation, magnesium sulfate, manage the underlying causes like hypokalemia, hypoxia correction. If it's because of ACS, then manage ACS, can consider beta blockers also. What is the role of pacemaker in torsade pointers? That's what you can use to correct the underlying cause. If it is bradycardia, which caused
Mm.
it, or it was because of some triggers, extra triggers which were there, or pauses which were there, which are precipitated at TDP, then you can consider a pacemaker. Otherwise, usual treatment is with the implantable cardioverter defibrillator. And even you can, I mean, what is the role of pacemaker in causing this arrhythmia? Even your pacemaker can result this if you don't time it properly, and if there is an R1T phenomenon, then it can, even your pacemaker can itself precipitate a loss of bone. And this was another CEP waveform which was given. I think this was a waveform which Dr. Sushmita had, Sakshi had highlighted. So this, I mean, you should know about the normal waveform. I put the normal waveform for your easy reference. So you can see in this particular case, there is a tall A wave, a tall V wave as well. And there is a steep X descent and Y descent. So this mainly indicates tight pericardium. So mostly it's in restrictive pericarditis or pericardial tamponade physiology. So one of these could be the reason where you'll see a steep descent of X and Y, and there's almost normalization of, I mean, equalization of pressures of A and V. So classically seen in restrictive pericarditis or pericardial tamponade. Sorry, I forgot to add the answer here. I think Tapas sir will add the next questions.
Yeah, thank you, Dr. Jitendra. You have covered well, and definitely, if you know the structure, how to answer, it becomes a cakewalk. So, with this, we will come to the Dr. Jitendra. Can you stop sharing so that I can?
Yes, sir, yes, sir.
Okay,
Yes.
perfect. So, I will be coming to the last part of our this webinar, which would be more of radio imaging and also the ventilator graphics. So again, it is very high yield scoring for you to pass the exam. So in the EDIC 2, so this was the similar city brain they have asked in the EDIC 2. Dr. Saksi, if you have anything, please add on.
So this
And
was not the exact CT, but there
yes,
was a thalamic bleed. So
yes, yes,
I think she was asking me for mentioning the ICP, like
yes,
to put in an ICP monitoring. But I think I kept on focusing on the finding of the CT scan. And she said, okay, what else, what else? But I did not get that she's asking me for ICP, if ICP should be done.
yes, yes, yes. So I would be now going with how to read this CT scan if it is asked in your any of your exam, not only in EDIC 2. So most likely diagnosis in this CT scan would be acute hypertensive large intracerebral hemorrhage, right basal ganglia thalamic with intraventricular hemorrhage causing acute hydrocephalus. So this would be the correct complete answer in the CT brain that is like no said here. Now the systematic description, again, this is a practice like format, not for the exam, because in exam you will not get this much of time to describe in detail, but any CT scan, X-ray or MRI, you should have a structure in your mind. So like in this, the most important thing that is obvious to everyone's eye is hyperdense parenchymal bleed in the right basal ganglia thalamic region. There is large volume intracranial hemorrhage with intraventricular extension into lateral and third ventricle. This is causing obstructive hydrocephalus with ventricular dilatation which is prominent. There is perilesional edema and also mass effect causing mild midline shift with effacement of ipsilateral ventricle. You can see I will be again showing you the CT brain. You can like appreciate all the changes that I have actually described here in the systematic way, and there is also no skull fracture which is obvious, and also no extraaxial bleed which can be identified. So this is a normal structure of reading any CT brain in detail. Now, as Dr. Saksi told, they will not be expecting you to read the CT in detail, rather what would be the management, because this is something a clinical exam. So the immediate steps would be to include airway protection if GCS is low, blood pressure control to systolic blood pressure 140 to 160 millimeter mercury. If there is any coagulopathy associated, so we have to immediately reverse the coagulopathy, and ICP control, as he told, with head up positioning and hypertonic saline if needed. Definitive management in this case would be CSF diversion via external ventricular drain for IVH related hydrocephalus, and craniotomy in this specifically like no asked question or CT brain if you are getting, it is not routinely indicated for deep ganglionic bleeds and supportive neurocritical care. As we all know, maintaining normothermia, normoglycemia, DBT prophylaxis after 24 to 48 hours, and frequent neurologic monitoring. So this would be in one, like you can like take in 1 to 1.5 minutes, if you can describe all these things, the salient points, you will get full marks. Now the detailed discussion related to intracranial bleed, I thought of like sharing also with you some knowledge related to the neurocritical care, or all the questions are having some take home message. So immediate priorities would be airway and breathing. We all know, I am not going into detail the circulation part, because the question includes what is the guideline based practice. So bp control is as per American Heart Association 2022, you should be targeting around 140 to 160. It should not be overcorrection, because otherwise it would be leading to ischemia. Now, hemostasis, yes, INR, APTT and platelet count. If patient is anticoagulate, definitely they may add on some of the anticoagulation if patient is on for some cardiac problem. So they would expect that you are saying that you have to reverse it immediately. And what are the reversal agents that you should remember? Now in European centers, they are mostly keeping their patients on dual oral anticoagulant. So you have to remember this new drug andexanet alpha, 4 factor PCC, warfarin if the patient is on 4 factor PCC plus vitamin K, and thrombocytopenia if the patient is having platelet less than 1 lakh or 100,000. Definitely we have to transfuse platelets. Now ICP or neuroprotection, as again like she narrated, we need to vocalize this word. Maybe they don't expect you to go into the tier approach of ICP, tier 0, tier 1, tier 2, tier 3. But yes, if you just mention about that, I would be monitoring the ICP and also titrate the ICP as per like my bedside non-invasive or minimal invasive way. So they would be very happy. So this will be in nutshell about this question. Now, definitive management, if they would expect that what would be the definitive management for this type of vessel ganglia and thalamic bleed, it is definitely external ventricular drain, which will be the first line. And again, in selected cases, in selected centers, they go for intraventricular altiplage just to lyse the clot. And also the surgical options, I have already mentioned craniotomy is not routinely recommended for deep ganglionic bleeds, but yes, if you are having cerebellar hematoma more than 3 centimeter with brainstem compression, lobar hematoma with neurologic deterioration, young patient and superficial bleed, it has to be superficial bleed, then you may consider surgical option in the form of craniotomy. Now, supportive ICU care, everybody knows about the supportive ICU care. Now, the second question, again, 27-year-old cyclist presented with head-on collision. This was the first CT brain that was done in the emergency department in your hospital. What is the diagnosis and what is the management plan CT wise? Dr. Saksi, can you just share the question and those expectation from the examiner?
Yes, sir. So straight away they were looking only for the catchy words. So straight away I said diffuse axonal injury is likely, and patient will need, after his airway breathing circulation taken care of, patient will need ICU management straight away. So they only wanted diffuse axonal injury. So after that they said okay. So they just wanted diagnosis. They did not ask for treatment for this patient.
Perfect. So diffuse axonal injury, grade 2 or 3. So you have to again revise the grading system for diffuse axonal injury following high velocity deceleration trauma, something related to again systematic CT description for your understanding and also practice. There is no large extraaxial hematoma, multiple small punctate hyperdensities at the gray white matter junction. This is the classical finding in case of diffuse axonal injury. There is also diffuse cerebral edema, how you are actually appreciating that in the CT brain, loss of gray and white differentiation, effacement of the sulci, narrowing of the ventricles. There is no skull fracture visible and no mass producing intracranial hematoma. So this is in nutshell about the systematic CT description. Now for exam relate like EDIC, they would be asking what are the red flags for DAI, diffuse axillary injury, when you will be like having a strong suspicion that my patient is having DAI. So in this patient, a 27-year-old cyclist with high speed impact. So classic mechanism is for related to DAI, rotational force, shearing injury of the axons, deep coma, poor GCS, despite there is no large bleed. So it is very unconventional that this patient is not having significant bleed or like midline shift, but the patient is in deep comatose state. So that is itself suggestive that this patient is having DAI. Now, typical clinical features for this patient: GCS less than equal to 8 at the scene, prolonged unconsciousness, posturing or abnormal motor response, autonomic instability, and some or other way patient may present with seizure, but it would be very less common. Now, why the CT looks near normal? This is again one question they may ask you. For that reason, MRI, GRE, and DWI is the diagnostic for DAI. So maybe the examiner ask you what would be the definitive diagnostic modality for DAI. Is it CT or is it MRI? So you have to mention about MRI. Now, maybe in the future, because DAI is something which would be always a high scoring question or domain. So they may ask you variant one. I have created these things just to like understand this clinical scenario in a very, I would say, lucid way. CT is normal, but patient deeply comatose. So suspect DAI, as we have like diagnosed this patient like this, MRI, GRE, and DWI to confirm, and the management would be just like severe TBI. Now, second would be patient develops deterioration in the next 12 hours. What would be your approach? The examiner may ask you. So you will be answering that I would go for rescanning for expanding contusions. I would also evaluate for malignant edema, aggressive ICP directed therapy. This should be one, two, three answers. How do you prognosticate? As everyone told that in the real exam, they would be always focusing on how you are good at the prognostication part or family counseling part. So these are the buzzwords they want to hear from you. MRI findings, brainstem involvement, poor prognosis. Pupillary responses, if it is not as per your expectation, definitely poor prognostication. Motor response on GCS, ICP trends, duration of coma, age, and comorbidities. These are the, like, you will be revolving around these findings so that your prognostication would be better to the family. And last but not the least, this is one like I would say we have got so many feedbacks from the trainees also. If somebody in case of DAI says that I would be like in the family meeting, I would say like early withdrawal of care. No, in DAI these patients are very unpredictable, so they would be recovering after you like take in like proper way the neurocritical care. So avoid giving early withdrawal of care timeline. So this would be most of the time you will be failed in the exam. Now, this is again one of the similar CT scan that was asked in the real exam. 24-year male, trauma, shortness of breath, diagnosis and management. Dr. Sakshi, anything you want to add during this question was asked to you?
They asked me, so diagnosis straight away, and with the site mentioned. This is not the exact CT.
Yes.
That was approximately this large pneumothorax. So they asked me for the site. I also said I will do ultrasound also.
Yes.
So she said okay, and I said ultrasound guided ICD insertion. And
Okay.
because the patient is unstable, I cannot shift for like any other in the OT or anything. So this will be done bedside ultrasound guided.
Yes, yes. So that is something right now the point of care test or point of care, I would say, intervention that we can do. And this is right-sided traumatic pneumothorax,
Hmm.
definitely non-tension at this point of time with lung
Hmm.
collapse. Most likely mechanism is blunt chest trauma in RTA. So you have to also mention it's not only pneumothorax, rather the lung is also getting collapsed.
Hmm.
Systematic description as like the city brain, I have created this for you. If you are getting time in your other exams, not in the time limited fashion in the EDIC exam, you should be starting with the pleura, then going to the middle. So visible pleural line on the right side, absent peripheral lung markings beyond the pleural line, lung appears collapsed and retracted medially, no mediastinal shift. So that means there is no tension at this point of time. No major refracture seen in this slice. Right lung appears somehow like over, like this collapsed lung is over aerated, and mediastinum is actually in the midline. So that's why we are taking this as non-tension at this point of time. Now, questions can come in a different way in the upcoming exam. What if this becomes a tension pneumothorax? So at this point of time, it is not tension pneumothorax, but if it becomes tension pneumothorax, immediate chest tube. In the recent ATLS guideline, they have actually removed the needle decompression. So maybe you should not be uttering the word that I would immediately go with the needle decompression. Now the space where you have to do the ICD or the needle decompression is both same. That is the mid axillary line, fifth intercostal space. Now immediate chest tube should be the first answer. Resuscitation, avoid positive pressure ventilation until decompressed. Otherwise, you will lose the patient. Patient will be severely hypotensive going into cardiac arrest. Now, variant question 2 would be, what if the patient is ventilated? Now, this patient is not ventilated and you are getting this non-tension pneumothorax. Now, if the patient is ventilated, always chest tube before positive pressure ventilation. Maybe you will try to avoid positive pressure ventilation if the patient is also intubated. Use low tidal volume. PEEP should be less than equal to 5 to 7. Monitor for barotrauma. Now, variant 3, what if there is also a hemothorax? So now we are only getting the pneumothorax. So maybe for hemothorax, you need to increase the size of the ICD or the chest drain, minimum 28 to 32. Otherwise, your fluid or the blood will not be drained out properly. If initial drainage is more than equal to or more than 1500 ml or more than 200 ml per hour into 3 hours, so the next management plan should be thoracotomy. So you should be involving your chest surgeons or the thoracic surgeons. Now, variant question 4, how to manage occult pneumothorax. So it is obvious pneumothorax. So you are definitely going with the definitive management. Now, occult pneumothorax, if ventilated, you should go for inserting chest tube. But if the patient is not ventilated and no distress, we can observe with oxygen. These patients, the lung will be now aerated, or this would be not like right now it is collapsed, but slowly gradually it would expand. Now, the next question, it was a very interesting question, and Dr. Saxi and Dr. Sushmita also remember that we have included this in our modules, our usual modules, TRICS 2. Anyone who can give me the answer before Dr. Sushmita or Dr. Saxi would actually share the answer. 42-year male, alcohol intake in party. So it was binge alcohol intake. And after the alcohol intake around midnight, he had intractable vomiting. And immediately this patient was presented with shortness of breath, shifted to the nearby hospital ER. What is the diagnosis and next plan of care? Anyone? Anyone? I want to check all of your GCS because I have already described the CT head of two patients in systematic way. So now I want to check that you are all with me or you are all maybe with the social medias or somewhere else. Yeah, I'm getting some answers in the chat box. Yes, since RF. Any other person who wants to share their thought process? Boyer, yeah, Swati. Okay, perfect. You all are right. So classical presentation, Dr. Saxi, you want to share? How was the
Sir, they didn't give history of protracted like refractory vomiting or severe vomiting in that. They said one patient came, this the female patient, I think it was, and I think they had put in an ICD and nothing was coming from the ICD. So what is your diagnosis? That something similar was the picture.
Yes.
And patient was not stable, so we could not do a CT.
Excellent. Yeah. So they somehow, like I have said in the previous two questions, some of the variants. So you don't expect that it would
Mm.
all be classical presentation. So
Mm.
as like she told, they have not given the history also properly. Okay. So this is a classical Boerhaave syndrome. So something you should know about Boerhaave syndrome is spontaneous full thickness esophageal rupture, usually after forceful vomiting. That is known as also effort rupture. It is a surgical emergency with very high mortality if delayed. Typical patient would be middle-aged male, sudden severe chest or upper abdominal pain after vomiting, alcohol binge or overeating history, rapid progression to shock or sepsis. Clinical features: classical severe retrosternal pain, subcutaneous emphysema. You can just feel the crepitus in the face as well as in the neck and the chest. Tachycardia, hypotension, dyspnea. Maybe there would be mediastinal crackling. So they say Haman's crunch. Investigations: chest X-ray like this, pneumomediastinum, left pleural effusion, pneumothorax, mediastinal widening. CT chest with contrast is preferred, but yes, you have to be very sure that you are not giving through the oral route, because sometimes oral route it would be like exposing the complete mediastinum and also the lung with the contrast. So, but yes, if you can do it, it would clearly delineate the esophageal wall defect. Air fluid leak into the mediastinum will happen. Periesophageal collection you will get, and hydropneumothorax, usually left sided, you can identify. Contrast esophagogram, again water soluble contrast leak you can see if you are doing the contrast esophagogram. Now, the treatment plan or management plan: early surgical repair, less than 24 hours, preferred in most cases. Primary repair plus mediastinal or pleural drainage. You can also add on or reinforce muscle or pleural patch in those leak areas in the esophagus. Endoscopic management is coming up in a big way in selected cases, and it would be more suitable for the contained leaks and the patient is hemodynamically stable. And some of the options you can have in your mind: self-expanding metal stent, endoscopic clipping, endoscopic vacuum therapy. There are a lot of non-operative or conservative management for like the small contained leak: IV antibiotic, NPO, NG tube decompression, percutaneous drainage. And the prognosis, again, everything at the end, you should remember the prognosis. Mortality less than 10% if you are treating within 24 hours, more than 40 to 60% if treatment is delayed more than 24 hours. Just remember, 23 hours, mortality is something else. 28 hours, mortality is almost 4 to 5 times. Mediastinitis is the main cause of death. So this is related to Boerhaave. Now this is also very interesting CT abdomen. Dr. Saxi, if you can
Sir,
just share.
I'm guessing this was the CT. I'm not sure that was the answer.
Hmm.
But they had given me a history of an elderly female who has severe abdominal pain. So I'm guessing that it was descending abdominal aorta aneurysm.
Hmm.
And this is not the actual question because I remember aneurysm, so I made that grading scores and what because they focus a lot on grading scores.
Very nice. So,
Hmm.
so yes, it is again a little bit difficult if you don't have like no, you have not seen related to the abdominal aortic. We all know about the aortic aneurysm rupture, but related to the abdominal part, yes, something you need to again like no, the revisit all those like CT abdomens. So based on diameter, you can classify. Normal is less than 3 centimeter, but yes, the giant abdominal aortic aneurysm more than 7 centimeter. Very high risk for the rupture. So this is like the classification based on the diameter. Based on the location: infrarenal, most common; juxtarenal, within 1 centimeter of renal artery; pararenal, suprarenal, thoracoabdominal. So these are the classification based on the location. Rupture risk, again prognosis: 7 centimeter, 30 to 50%; less than 4 centimeter, less than 1%. And risk dramatically rises with diameter, growth rate, smoking, and uncontrolled blood pressure. And CT features suggestive of pending rupture: you will get a crescent sign. They also name it as draped outer sign, retroperitoneal stranding, rapid expansion. Every year more than 1 centimeter like expanding. Focal discontinuity of intima. Now, some of the important question for EDIC, because nowadays they are actually focusing on this abdominal aortic aneurysm or ascending aortic aneurysm. So, absolute indications: ruptured abdominal aortic aneurysm, and EVAR, that is endoscopic, the endovascular aortic aneurysm repair is preferred. So, you should mention about this if anatomically feasible, and if you are getting symptoms like abdominal aortic aneurysm with pain, tender pulsatile mass, distal embolization, definitely they are the absolute indication for surgery. Size based indication, men more than equal to 5.5 centimeter, women more than equal to 5 centimeter because of higher rupture risk. If your abdominal aortic aneurysm is rapidly expanding, growth is more than equal to 0.5 centimeter in 6 months or 1 centimeter per year, as I have told. So this is something we need to consult the surgeon and immediately go for surgery. And saccular aneurysm, they are having high risk of rupture. So repair is recommended. Now this is again one more, like again, CT abdomen, Dr. Saxi.
So I have picked up emphysematous pyelonephritis, but that CT they had given just this image. They did not mention anything. They did not mention history of fever, or I think they mentioned history of trauma. I think if I vaguely remember, abdominal trauma. They did not mention the age of the patient. So
Hmm.
like I was also confused, and I had asked for another view of the CT, but that was not available. But
Hmm.
she gave me enough time to go through it again and again. So
Okay, okay. So if you are getting similar to the city, definitely everyone can appreciate that the kidney on the left side is actually right now emphysematous with like no air inside the renal parenchyma. So yes, so it is emphysematous pyelonephritis. It is a necrotizing, life-threatening, gas-forming infection of the renal parenchyma and perinephric tissues. Some of the major risk groups: diabetics, 90%. Immunocompromised, urinary tract obstruction, female more than male. Pathogen, E. coli is most common with Klebsiella following, Proteus, Pseudomonas. Clinical presentation, high-grade fever, flank pain, septic shock, GCS low, AKI, refractory hyperglycemia. Diagnosis, CT. CT scan is the gold standard. It can show the gas within the renal parenchyma collecting system or perinephric space. Sometimes you can start with KUB ultrasound, may show that is shadowing, but that is not reliable. So CT is the gold standard. In exam, you have to answer this. There is a CT classification also about this emphysematous pyelonephritis, class 1, class 2, class 3A, B, and 4. Why they have divided on this basis of CT abdomen, and a classification is existing just for this reason, because we have to prioritize our management based on the CT finding. So resuscitation, as we all know, if you are getting a patient in your emergency, in your ICU, acute pyelonephritis, acute emphysematous pyelonephritis, you have to follow the sepsis bundle. Source control depends on the CT class and the stability. Medical management, you have to go if you are getting class 1 or class 2. Patient is hemodynamically stable, no other organ dysfunction. First and foremost thing, if you can do it, percutaneous drainage, that is treatment of choice for most patients for class 2 and class 3. When you are getting abscess, gas pockets, obstruction, that is markedly improving the survival. And in the same setting, you can also combine with stenting if there is obstruction. So this is the treatment option second. And the last one would be nephrectomy. And nephrectomy, if you are getting the CT classification class 3B 4 with shock and failure of percutaneous drainage previously done, but patient is not responding, extensive necrosis is there, patient is deteriorating despite your antibiotics and antifungals, and multi-organ dysfunction. This is nephrectomy. Now, something related to this ventilator graphics. Again, ventilator graphics, you have very limited ventilator graphics. And if you are thorough in all those, like, these domains of ventilator graphics, I think you can score it very well. Dr. Saxi, Dr. Jitendra, anything you want to add before I will be just going through? I think 3 ventilator graphics are there.
so there was a respiratory distress in the patient. So
Yes.
this was a double triggering patient. There was
Yeah.
ventilator dysynchrony, double triggering. So they didn't ask me what it is. They asked me what will your next management be.
Yes, yes. So the questions can come in any way. There are, like, at maximum 4 triggering, reverse triggering, double triggering, auto triggering. So you have to be very thorough. This would be one of the pet question from the examiner related to triggering. Now, I would be just describing about the double trigger. Two ventilator breaths delivered back to back because the patient's inspiratory efforts are actually outlasting the ventilator set inspiratory time. So the patient is actually automatically having two breaths within the same inspiratory time. What it looks like on waveforms, there will be two consecutive pressure strokes with no exhalation in between. Classical. Volume waveform shows breath stacking. Flow waveform shows continued inspiratory effort after your ventilator cycle is off. So three very specific characteristics that you can mention in your exam. What would be the impact if the patient is having double triggering? There would be increased tidal volume, and as a result, what will happen? There would be consecutive two like the breaths happening. So there would be stacked breaths. Risk of volume trauma. In ARDS, this is definitely harmful because we are targeting low tidal volume up to maximum 6. But if it would be two consecutive, so as a result, what is happening? Increased tidal volume is actually delivered to the patient. So maybe that can reach up to 12 ml per kilogram in certain breaths. So that is dangerous for this patient when the patient is on a high PEEP and the lung condition is not good. So that would be causing dysynchrony, discomfort, agitation, and air hunger. The patient needs to also exhale, which is not happening. Now, what are the causes of double triggering? Air hunger or high respiratory drive. There are n number of causes in the ICU on the ventilated patient. Pain, anxiety, metabolic acidosis, fever, sepsis, hypoxia, hypercapnia, and sometimes neurologically driven. So there is no control. The neuro center is actually driving the respiratory drive. Now, ventilatory inspiratory time too short. That could be possible. So the neural inspiratory time, which is having like the patient side, is actually more than the mechanical inspiratory time, which is from the ventilator side. So the patient's neurons are actually sensing it, and they inspiratory time is actually prolonged, but the mechanical ventilator inspiratory time is shorter. Tidal volume too low, so that may be not meeting the patient demand. You are keeping the patient's tidal volume low to just protect the lung in ARDS. That is a common cause. So you have to take care of that part. Inadequate inspiratory flow. So you have to maintain or increase the flow, inspiratory flow, so that it can meet the patient's inspiratory demand. Right? How to fix it? As she told the management, you have to sometimes just like mention the management part rather than all this theory part. Increase the inspiratory time. This is the first and foremost thing that you have to do. Match the patient's neural inspiratory time. So the ventilatory inspiratory time is less. So you have to actually increase the patient's neural inspiratory time. In pressure control mode, you have to prolong the inspiratory time. In pressure support ventilation, you have to actually adjust the cycling criteria 25% to 10% so that the patient can go into the next cycle. Increase the tidal volume slightly if safe. Like in ARDS, we cannot increase to maybe 8 ml or 10 ml per kilogram, but yes, predicted body weight, if we calculate maybe 6.5 to 7 ml, if it is not hampering with your like other ARDS targeted ventilation. In non-ARDS patients, yes, increase the tidal volume to patient comfort. Increase inspiratory flow. We can easily do 60 to 80 liter per minute in volume control. Makes the breath faster and fuller, and the patient will be happy, satisfied. Reduce the respiratory drive. Maybe that is again the fourth option we have. And for this, we can use or administer analgesia in proper dose, light sedation little bit, correct the acidosis, treat fever, sepsis, and optimize the oxygenation. And finally, change the ventilator mode. Maybe you have to have like assist control, pressure control with longer inspiratory time. Sometimes people say Nabha is actually best known for synchrony with the neural as well as the mechanical ventilator like way, and sometimes APRV because you are maintaining the spontaneous breaths in the APRV mode. Now, this is again another ventilator graphic similar to this was asked. Anyone who can answer this? What is this ventilator graphic is showing?
So flow starvation, the scooped
Yes.
appearance.
Yes, yes, yes. Very classical. I told ventilator graphics is very easy if you have like no have your own question bank of around 20 to 25 and read it, answer the like no the anomaly, the pathology, and what is the management. These are the 2 to 3 very specific questions they would be asking. Now I am not going into detail. Forced starvation is a form of patient ventilator dysynchrony that occurs when a patient is demanding more flow than the ventilator provides. Very simple. So visual inspection, like we just like appreciated that inspiratory waveforms is often like sufficient to detect flow starvation. So you can just easily see it, and this would be seen in volume AC ventilation due to the fact that flow is controlled. Now patient is pulling the flow from the circuit, which drops the pressure in the system. Some ventilators have auto mode. They are actually adding or allowing additional flow when the pressure drop in the circuit exceed a predetermined amount. So this is something automatically the ventilator can sense and also justify it. Now, what are the management plan? Set the inspiratory flow appropriately when you use the volume assist control. Most adult patients, they are comfortable with a flow rate around 50 to 60 liter per minute. But if pressure control, assist control is used instead, you need to closely monitor that the delivered tidal volume is actually ensuring the patient's need, the tidal volume, whatever they are actually, they require that, and that has to again go with sync with the lung protective ventilation. So these are something you need to have in your mind. Now, how to fix the air hunger? Already described in the last one also. You have to increase the tidal volume carefully, increase the inspiratory flow, already described, increase the inspiratory time so that the patient will be getting longer inspiration, and that would be matching the neural inspiratory time. Sometimes you have to switch the cycling off criteria from 25% to 10%, reduce patient drive, and change ventilator mode if needed. Now, this is again something very interesting, very usual. Every time in our ICU, 2 or 3 patients will be getting this type of ventilator graphics. Case of COPD on ventilator, and the patient is hypotensive now. Dr. Saxi, anything you want to add? So this is related to auto PEEP, intriguing PEEP, and very standard question in any of the critical care exam. I'm not going into detail, just showing you the main points so that you can appreciate what can be the questions. COPD, asthma, severe airflow obstruction, tachypnea, mechanical ventilation with very short expiratory time. You will get auto PEEP. Waveform clues, flow is not coming to zero and end expiration, and elevated end expiratory pressure and ineffective patient triggers. Okay, how to recognize auto PEEP? Again, flow waveform, flow should not be normally like flow should return to zero, but if it is not coming to zero, auto PEEP is present. You can appreciate it through the esophageal pressure, expiratory hold maneuver. They would ask you what are the like maneuvers that you can do at the bedside, and what are the clinical clues: high respiratory rate, tachycardia, hypotension, and patient fighting with the ventilator. Now there are a lot of like I would say 1, 2, 3, 4, 5, 6. How to fix auto PEEP? Most important is increase the expiratory time, reduce the minute ventilation. Automatically you will get some expiratory time more. Add external PEEP. That is again sometimes the examiner would expect you that you are very confident of like managing the external PEEP and internal PEEP ratio. If you are getting external PEEP very high or auto PEEP, so you have to set the external PEEP around 70 to 80% of the increasing PEEP. Reduce the airway resistance with some of the medications, nebulization, suctioning the secretions, fixing some of the like the troubleshootings. Reduce patient drive, and if severe dysynchrony, you have to switch the mode, and last but not the least, consider paralysis temporarily just to break the auto PEEP. Clear? Now last but not the least, I would say they are very fond of now asking about TEG or ROTEM. I'm not again going into detail. I have just got this from the one pager. So you have to be very thorough, and the questions are very straightforward. If you understand the concept and the graph, how like what will be the pathology, so you can answer what will be the management. very systematic. Fifth term, like what is the like the management for that, something like that. Dr. Saxi?
Sir, I think I don't remember correctly, but there was a question on road temp with fifth temp. So that initially, because the values were very small, I had skipped. Then in the last, I came back again and I said, they just asked, what is the correction? What do you do? So I
Exactly.
said cryoprecipitate or fibrinogen complex. So they said, okay.
Very nice. Okay. So I am now completing the webinar with few of the take home message for all of you. It's not about only teaching. This is just eye opener webinar. We have lot of things to come. One like introductory webinar also, which would be, I think, scheduled towards this month end. And also we are coming up with the full modules, the course from next month onwards. But yes, never leave a question hanging. The examiner doesn't like it. Always close with a clear plan. Like if you are, even if you are unsure, your answer should be, my plan is to stabilize, to diagnose, to treat and reassess. You may not be always 100% correct in your treatment from the very beginning. But yes, if I will be reassessing, I can again rectify if I am going in the wrong direction. That would be, the examiner would be very happy, or they will rate you as a safe ICU doctor. And ultimately, they want that also, only. That if I am passing you or I am certifying you as like a consultant, I am very sure that they maybe you are not able to like always have difficult diagnosis or management, but you are a very safe ICU doctor. So this should be the take home message number one. And some of the preparation summary I have actually like created: master ventilator and arterial waveforms. All these things I have already told, master it. Have at least 50 to 100 like this type of waveforms, all these like curves, ECG, on some of the like TAG, ROTEM. Nobody can like ask anything beyond this. Waveforms 30 to 40% of EDIC 2. Interpret them instantly. Use always a strict ABCD structure for every scenario. Imaging, ventilator, shock, ECG, ABG, IABP, whatever may be. And the ABCD stands for A, secure airway, V, ventilation ABG, C, fluid pressure, D, diagnosis, and E, evidence-based plan. Know some of the key cutoffs. They are very fond of now the cutoffs and the scoring system as told by our two trainees and the examinees. Think like an ICU consultant, already reiterating the same thing by the like which was told by Dr. Sananda and Dr. Jitendra. They want you to behave like an ICU consultant. No more you are like a trainee. Clear? So prioritize, stabilize, and prevent deterioration. This should be the take home message. Always state, my first priority is something like that. And always remember what will kill the patient next. If I am doing this, the examiner will fail you. Okay. And EDIC is a safety and decision making exam, not a memory test. I am very thorough and clear about this. We have taken feedback from many candidates over last couple of years. They want that, yes, whatever you say, this is safe for the patient, safe for the hospital, safe for the society. And you are very clear in your decisions. You are not confused. If they just like appreciate that you are confused in the exam, they will not pass you. And practice 50 to 100 EDIC style cases for each of the tables in the CBS, because CBS is very difficult as per our feedback over a couple of years. And try to reduce the time frame. If you at this point of time expressing everything that we discussed in 2 minutes, but if you practice in next 2 months, 3 months before your real exam, maybe you have to touch the 30-second mark. If you are expressing everything in less than equal to around 30 seconds or 45 seconds, you are through the exam. With this, I think we are just 9:08, 2 hours since we started our this webinar. Please share your feedback if you liked it, the approach, the coverage, because the faculties have given their best effort to bring the current trend in the EDIC 2. And I am really like happy that we have got a very encouraging feedback, and also people have registered across the world. Thank you, Dr. Jitendra. Thank you, Dr. Susmita. Thank you, Dr. Saxi, for sharing your knowledge and expertise to all the interested candidates who are planning to appear the EDIC 1 or EDIC 2 exam. Please keep tuned, stay tuned with our upcoming webinars. And if you have any queries, please feel free to post in the WhatsApp group. We will be definitely, one of us will be clarifying your doubts. And any questions or anything before we conclude for the day? I'm just right now. Sanant, if you are also there. Sanant, any concluding statement?
No, I think you have made it pretty clear. And I want to emphasize that it's not about only studying for a week or two for this exam. So this is a practice-based exam. You have to practice all these things in your daily practice, like practice in ABG, practice in ECG, X-ray, how to speak about it. So if you do it for next 3 months, you'll be very ready for the exam. You think you will just study during the last 7 days, it is not going to work out like that. So it has to be in your practice, then only you can answer these questions in the exam.
And the bonus point would be you will be clearing your exam and also very confident in your clinical. So people have always expressed to all of us that maybe the exam was like, no, they have been successful or not, but yes, in real clinical practice, in their day-to-day clinical practice, they are more confident after attending our like no course and also preparing for the EDIC. Dr. Jitendra, anything?
Nothing, sir. I think you have covered most of it.
Perfect. And Dr. Saxi and Dr. Susmita, any concluding points for our like the trainees, or else we'll wind up?
So actually, I would like to say that the examiners are very, very helpful. They're very patient. I mean, I was under the impression that they're going to be like very strict, but they were very helpful, and it was more like a communication. So it was quite the rapport was quite good. I was very stressed unnecessarily. I was stressed, but they were very helpful.
Very motivating words. At least the upcoming trainees would be happy that yes, we may get a very good examiners in our real exam. So thank you very much. And with
Okay.
this, we conclude our webinar. Merry Christmas and Happy New Year in advance to all of you. And we wish you that you will be clearing your upcoming exams, maybe EDIC or any other exam successfully. Thank you very much.
Thank you, sir. Thank you, everyone.